Hey guys, this is Aaron with Ross Training Academy. Today we're just going to be going over stroke care, just basic stroke care. So let's go ahead and just get into the lecture. So what is a stroke? A stroke is just going to be damage to the brain caused by an interruption of blood flow. This can be caused by a clot to the blood vessel or an ischemic stroke, or it can be caused by a damaged blood vessel like a hemorrhagic stroke. You may also hear a stroke referred to as a cerebrovascular accident or a CVA. Some strokes might start showing their effects within seconds to minutes. Others might take minutes to hours, but they are all going to be life-threatening if left untreated. And a stroke, even if treated, can cause lifelong deficits. And then I will go ahead and say that a stroke can happen at any point in your life. It is most common in ages 55 and greater, but from the moment you're born, you can have a stroke, unfortunately. So it's good to know signs, symptoms, and just basic treatments for a stroke. So what are the different types of stroke? We have a hemorrhagic stroke, and that's just going to be a blood vessel ruptures. This is going to decrease oxygen and increase the buildup of CO2, which will then also increase intracranial pressure. CO2 acts as a vasodilator to the area, and so that's also why it will increase the intracranial pressure, or the ICP. I guess good news, a hemorrhagic stroke, although is more severe, will typically cause more significant signs and symptoms. It does happen less often. The more common stroke is going to be an ischemic stroke, which accounts for about 80% of all strokes. And this is just going to be a blockage to a blood vessel in the brain, or plaque causing constriction within the vessel. A little bit less likely is just going to be an air embolism, which can also act as an ischemic event towards the brain, causing that ischemic type stroke. And then the third type of stroke that we're going to kind of talk about is going to be a transient ischemic attack, or a TIA. This is going to be referred to as a mini stroke, partial stroke, temporary stroke. And it's just going to be by a partial or temporary occlusion of a blood vessel in the brain. This typically will resolve itself within about 24 hours, but it is still a life threat. You should still go to the hospital to receive care because you have a clot that's now just floating around your body, even though it moved from your brain, which is why it's self-resolved. You still have a clot somewhere, so you can still have that ischemic stroke. So, some basic stroke care, and not necessarily in any type of order. We're going to go ahead and we're going to call 911 as soon as we recognize it. If you're in a hospital, call a code stroke. Rapid transport if you're a 911 provider or in EMS. We're going to obtain a blood sugar reading, a blood glucose reading. High or low blood sugar can cause altered mental status and weakness, which can be similar to a stroke. So just rule that out. Check the blood sugar. We're also going to go ahead and check a 12 lead, check out the heart. Heart abnormalities can cause very similar symptoms of altered mental status and weakness. So check out the heart, rule that out. We're then going to try to get an IV. Hopefully we're going to get the IV. A large bore IV, preferably bilaterally, both arms. But if you can only get one, just get the one. And then we're going to go ahead and start treating the hypoxia. We're going to start giving oxygen. If the person's SpO2 level is at 94%, below 94%. If it's at 94% or above, they don't necessarily need oxygen because oxygen acts as a vasoconstrictor and can worsen patient outcomes by decreasing cerebral blood flow that is already being decreased from the stroke. We then want to get an early CT as soon as possible and get somebody who's trained to read it. The initial CT is not going to use contrast just to help rule out a hemorrhagic stroke, and then they would do a CT with contrast to find an ischemic stroke. If it's an ischemic stroke, they're going to go ahead and give a fibrinolytic, such as TPA. TPA needs to begin within about 4 hours of stroke onset, and for the IV, and then about 6 hours of stroke onset if it's going to be arterial. We will not use any blood thinners, clot busters, TPA, anything like that if it's a hemorrhagic stroke, because they're just going to keep bleeding. A hemorrhagic stroke, what we're going to do for this person is beta blockers, anticonvulsants if they start seizing, vasodilators to help lower that blood pressure, lower the amount of blood that's exiting through the open blood vessel, and monitoring. There might even be like clipping of the vessel. They might do burr holes. They might do a vessel repair, but that's going to be all at the physician level. For an ischemic stroke, they might give that TPA. They might give a blood thinner, anticoagulant. They might consider a beta blocker. You want to use caution with the beta blocker just because the high blood pressure is what's going to be helping to perfuse the brain. You have a blockage in the brain. So the higher blood pressure is going to bring more blood to the brain. That's going to go not necessarily around that clot, but into other blood vessels to help perfuse the brain as much as it can to compensate for that clog. And then they're going to do a thrombectomy, or they might even do a vessel stent. Just get that clot out, open up that vessel some more, and that's what they'll do for the ischemic stroke. So to identify a stroke, we want to use the acronym BFAST. And all that stands for is the B is going to be balance. We're going to be looking for an altered walk with an unknown cause. So if they were drinking alcohol, if they were drunk, we can't necessarily use this one. So that's why it says an unknown cause. We're going to be looking at the eyes. Not necessarily eye drift, eye droop, but vision changes. Vision loss, blurry vision. Those could be signs of a stroke. We're then going to be looking for facial droop. So is the patient's face symmetrical? We're going to go ahead and ask the person, just, hey, smile, show your teeth. And we're going to be looking for one side of their face to droop downwards or just not be as strong as the other side. The A is going to be for arm drift. So we're going to go ahead and have the person just close their eyes, hold their arms straight out in front of them with their palms up. And then we're just going to count to 10. We're going to see if there's any weakness to one extremity or the other. We're going to look for a quick drop or even a slow drop to the weakened side, that weakened extremity. The S is just going to stand for slurred speech. Is the patient talking normal? Do they sound normal? Are they making sense? We want to confirm this with the patient. Just, hey, do you feel like you're talking normal? They should be able to tell you yes or no. They might be able to tell you yes or no. But we also want to confirm with the family, with the friends. How is this patient normally acting? Do they typically talk this way? Do they just need their dentures put in to talk better? Just little things like that. And then we have T for time. This is going to initiate a lot. The time from their last seen normal will kind of guide the treatments a little bit. Definitive stroke care needs to occur 12 hours of onset of symptoms for the best results, but the sooner from the onset of symptoms, the better. So for their last seen normal time, for example, if the patient's family member went to bed with the person last night at 9 o'clock and they woke up in the morning at 10 a.m. and the patient's acting this way, well, the last seen normal time for that patient will be 9 o'clock that prior night because that was the last time you saw them normal is when you went to bed. Now, a different example. If you both wake up together in the morning, everything's fine. You go outside to smoke a cigarette for 10 minutes. You come back inside and now the patient's acting like they're having a stroke. Their last seen normal time is going to be 10 minutes ago. And that's what timing means. Some other stroke symptoms that shouldn't go overlooked is going to be numbness or weakness to the body. So we can test the patient's grip strength. We're going to place our fingers in between their hands and tell them to squeeze our hands as hard as they can. And just see if it's symmetrical. See if the strength is symmetrical on both sides. We're also going to be looking for confusion, for memory deficits. They just can't really remember things. They can't remember what color that is. They can't remember what their name is. They can't remember what your name is. And then we're going to be looking for a severe headache with an unknown cause, lack of coordinated movements, if the patient is having a seizure and doesn't have a history of seizures. Somebody having a stroke may also be nauseous. They may also be vomiting. Some things more specific to a hemorrhagic stroke is this person is going to look bad. They're going to look very sick. They're going to be very lethargic, very weak, very pale, diaphoretic, their blood pressure is going to be very high, and they're going to be the most altered, AMS, altered mental status. It's going to be very significant for these patients. And typically the onset of a hemorrhagic stroke, how fast the symptoms come on, is very quick, within seconds to minutes. The ischemic stroke, some signs and symptoms more associated with that. We're still going to see that high blood pressure. We're going to see pretty good headaches, pretty significant headaches, and then photophobia, or just the light is hurting their eyes, essentially, and they want it to be very dark, very dim. And then with an ischemic stroke, the onset of symptoms, the onset of their signs and symptoms is typically going to be a lot longer. So it's typically going to be those minutes to hours is when they're going to start presenting in this different stroke-like way. Now let's talk about some things that might mimic or fake look like a stroke. So sepsis, just a severe systemic infection to the body, can mimic a stroke with that weakness, altered mental status. Meningitis can also mimic a stroke. A complex migraine. We have Bell's palsy. Bell's palsy is typically going to be from an infection, such as herpes simplex 1 or cold sores. Nobody really understands it too well, but it's an unexplained paralysis treated with steroids and antiviral medications. With Bell's palsy, when you ask the patient to smile, ask them to raise up their eyebrows, typically the forehead, the eyebrows area, is going to be paralyzed. It's not going to move on one side or the other. Whereas with a stroke, strokes typically spare the forehead muscles, meaning if you ask the patient to raise their eyebrows and they're having a stroke, they typically can do it, but they will have the mouth droop. Bell's palsy, they won't be able to raise their eyebrows, and they will have that facial droop. Seizures. Todd's paralysis. This is going to be temporary paralysis following a seizure. That can mimic a stroke. They're not going to be able to talk to you. They're going to be weak. They won't really be able to move. This can look like a stroke. Strokes can also cause seizures. So we don't know necessarily in the emergency setting which one caused which until we start doing those CT scans. And then head injuries, brain tumors, cardiac abnormalities, hypo or low blood sugar, hypoglycemia, can all mimic strokes. So, when should we be calling a stroke alert? Typically, it's going to be about 6 hours of onset, or they woke up with these symptoms. That's when we're going to be calling that stroke alert. We have to make sure that their blood sugar is relatively high. We would like to see it above 60, but 60 is about the lowest that we would like to see it if we're going to be calling a stroke alert. Even at 60, you might even consider giving them some dextrose just to try to increase that blood sugar, just to see if it's really a stroke issue or a sugar issue. Or you want to look and see what the patient's normal is, so ask the family what the patient's normal blood glucose reading is, and go off of that. If the patient meets the B fast or the fast criteria, and then if the patient meets stroke criteria, but you're unable to get meaningful information from the patient and others on scene. So if they have stroke-like symptoms with an unknown last seen normal time, we're going to go ahead and just call the stroke alert. So some questions you would want to ask the patient. Have you had a stroke in the past? Do you have any deficits from your prior stroke? Is one side always weaker than the other? Did you receive those clot-busting medications, or did they have to do some sort of surgery? What did they do? Is anything about this time feeling different? Do you feel different? Are you acting different? Or is it about the same as your prior stroke? Did you wake up with these symptoms? If so, when did you go to sleep? Did you have a seizure before the symptoms began? Are you on a blood thinner? Why are you on a blood thinner? Do you have a history of AFib or atrial fibrillation, or that abnormal heart rhythm that could be throwing clots around your body? But that's about it. Very basic lecture, just very basic stroke. Hope you guys enjoyed, but that's it for this video. Thank you. Bye.